Hi, I'm Nikki Schultek, and I'm honored to be here today for a series I host called Brave Scientists with Dr. Herb Allen. Herb is a dermatologist by training, and he is full professor and chair emeritus of dermatology at Drexel University College of Medicine, as well as an adjunct professor at the Eastern Virginia Medical School. Herb, it's wonderful to have you here today. Thank you so much for joining me.
Thank you for having me.
So what I think is so cool about your career and your research is that you are doing something that is one of my favorite things, which is kind of breaking down silos in medicine and research and bringing things together that might seem to be unrelated, but are related. And I wanted to ask you first if we could chat a bit about how a dermatologist gets interested in something like Alzheimer's disease, which is something that you've been publishing on.
Yeah, the story, I had known about Lyme disease for a long time because that's a dermatology disease first, with the erythema migrans bullseye type of lesion coming first, if you have one. And so that was in the background. And then I had been working with eczema and psoriasis to study whether that might be infectious, and had shown that both of those diseases are biofilm diseases. So in eczema, it's biofilm that is made by the staphylococci that are normal residents on skin. And in psoriasis, it's streptococcus, but it's not in the skin, it's actually in the tonsils. So psoriasis is different, even though the skin lesions are there and are characteristic, the actual infection is in the tonsils. And then that work had expanded to include leprosy, which probably is the greatest achievement of medicine in the past 50 years. Leprosy's gone from an incidence of 15 million per year down to less than 1 million. And the reason that happened was rifampin, which is a biofilm dispersing agent or buster, was added to the regimen of dapsone. And so you add dapsone in, and it wasn't added because it was a biofilm buster, because it was unknown at that point in time. It was added just as another antibiotic. And fortunately, they chose the right thing. And that has completely revolutionized the treatment of leprosy. Leprosy is also, it's got lesions in the skin, but the biofilms are in the liver, spleen, and kidney, not in the skin. It's like psoriasis, where the biofilms are in the tonsils, and leprosy, where the biofilms are elsewhere. So those diseases got me going. And then I read that our colleague in Switzerland, Judith McCloskey, had found Lyme organisms in the brains of Alzheimer's patients. And then I said, well, I wonder if they're making biofilms there. And so I took the same methods that we use pathologically in the skin and tonsils, and looked for biofilms, and lo and behold, they were there. I had learned then that McCloskey was preceded by Dr. Alan MacDonald, who discovered Lyme organisms in the brains, and he was the first one to do it. He presented his data to Journal of American Medical Association, and they wouldn't publish it.
Wow.
which was an amazing thing. I mean, here he's got a completely new thing, and they thought he was crazy, and wouldn't publish the findings. And then Alan then showed that it also made biofilms pretty much around the same time I did, and the one difference was that I had shown that just like the skin, the reaction to the immune reaction to biofilms is with the innate immune system molecule toll-like receptor 2. So toll-2 was found in the skin in both eczema and psoriasis, and I found it in the brains of Alzheimer's patients. So it kind of, the whole thing mirrored previous work. So
it sort of builds a bigger picture, right, around not just focusing in on one system of the body or one organ, where you can miss really important, conclusions that can be drawn, right? Because here you are looking at the skin and looking at these issues, and while there's a great deal of complexity, it's possible that some of the issues are a little bit simpler maybe than we realize initially. That some of the systemic infections like Lyme, since it's intracellular and obviously can hide out inside biofilm and avoid being detected or eradicated, it can obviously enter the CNS. We know that, right? Because people get
absolutely
neuroborreliosis. And we know
correct.
Other spirochetes can enter the CNS and cause a great deal of trouble.
Yes, so that became the next focus for Alzheimer's disease. But just going back a little bit, the biofilms can be outside of cells, which are extracellular biofilms outside of cells. The biofilm is actually made up of extracellular polysaccharide material, but that's outside the bacteria, not outside the cell. And then they can be inside the cell. So the biofilm is inside the cells, and that's both bacterial and viral. So I then have gone with the skin part of it on studying viral biofilms, and have found them in a common skin disease called Molluscum Contagiosum, which are tiny little wart-like growths. They contain biofilms, and the molluscum biofilms, but that's all intracellular because the virus cannot make biofilms outside of cells. It has to hijack the DNA of the epidermal cell and then turn that into the biofilm factory.
So, Herb, when you're talking about the importance of viruses too, it's funny that you mention it, because I was going to ask you about this. Obviously, the Alzheimer's disease literature, in terms of the infection hypothesis, demonstrates that a multitude of organisms are there, actually, right?
Correct.
So,
absolutely.
what are your thoughts on the possibility of an organism like a spirochete, for example, or any other intracellular parasite, if you will, leading to other opportunistic infections like reactivation of herpes? Have you thought at all about sort of the order of operations in terms of the infectious diseases?
I think actually the spirochete is first. And then the other, and it makes biofilms, and then the other organisms then reside in the biofilm, which is clearly shown in the dental biofilm structure, for instance. So plaque is made by Streptococcus mutans, which attaches to the tooth, and then Porphyromonas gingivalis joins the biofilm, and last the spirochetes, Treponema denticola is a short for all the other dental spirochetes, but it's kind of I think of it as a hotel rather than a single family home.
Yeah, I've been calling it, at times I've discussed with other scientists, and I started thinking about organized crime, like a crime
Yeah,
family, where you
yeah,
have different parties there doing their nasty business. And, particularly things that are intracellular, which viruses are by nature, but certain bacteria and fungal pathogens, parasites, can really wreak havoc on the inside of cells. And so it would seem like it makes sense to explore it. But of course, one of the major hurdles in terms of, and this well, the infection hypothesis of Alzheimer's disease is demonstrating that those agents are actually causative. And,
correct.
I really did enjoy Judith McClossy's paper on the fulfillment of modified Koch's postulates with spirochetes.
Yeah, Koch-Hill postulates.
Yeah.
Yeah, that was really good. The other thing that she did, which was really compelling, was show that the pathology of a pure spirochetal disease, which is syphilis, is exactly the same in the brain as Alzheimer's disease. Exactly. Same plaques, same neurofibrillary tangles, same atrophy, and they mirrored each other exactly.
And Herb, remind me, am I correct in my memory here that syphilis exposure and then the time that it takes to develop neurosymptoms, there can be quite a delay?
Years.
Right?
Years.
Even a decade, right?
More than that, even.
So the idea, so then wouldn't you think, so I'm sitting here going, well, it's kind of like a Captain Obvious statement. If you can induce that type of pathology with a known agent like syphilis, which is a spirochete, right, in the same family as something like Borrelia, and you can show this, then wouldn't you think that would be pretty compelling for the field? I would think it would be.
I think it's dramatic, and I don't understand why it hasn't gotten a whole lot more acceptance, because it's hard evidence, if you will. The other thing is regarding other organisms. The Porphyromonas is a bacterium, a gram-negative bacterium, and it can make biofilms in minutes. The spirochete takes up to 2 months to divide, number one, and then it takes 10 cells in every direction to make a biofilm. So if you show it horizontally and vertically, and then make a sphere out of that for a biofilm, you can figure out how many organisms how many it takes to create a biofilm. And then that whole process can take up to 2 years to make a single biofilm from a spirochete.
So what you're kind of honing in on is the fact that you can be exposed to some of these things, or they can begin to get an edge on you as you age, when immune function wanes, or perhaps you've been exposed to a multitude of infections or environmental factors are at play, like diet, exercise, overall health, and you become perhaps more vulnerable to the work that they're doing, right? This chronic inflammation.
So what I'm saying is that it takes a whole lot of time to make the process, and that fits with the development of Alzheimer's disease. It takes a long time for that to happen. Where Porphyromonas, it would be 5 minutes, and they would have a biofilm, and that time frame does not fit with the actual clinical disease. Or herpes, which is same thing for division, and making a biofilm intracellularly, it will happen really quickly. So I think of those organisms as being less likely to be at play in the disease, and that's the thinking behind it.
Yeah, it certainly is a confusing and difficult landscape, right? Because the brain is hidden away. And so our ability to study it while somebody is alive is limited by the constraints of what a delicate organ it is and then how it's concealed, right? Unlike
Correct.
other areas of the body, like the skin, for example, which are easier to take a biopsy and examine in a living person. But one of the questions that I wanted to just posit with you, and because it's something that I think about a lot as we build these research collaborations and think about ways of studying this problem and attacking the problem, is then in this case, if it's something that's building over many, many years, then wouldn't it stand to reason that the best way to attack it would be a strategic intervention that prevents it from happening in the first place, right? Like a
Correct.
vaccination approach? Or
well, that would be great if you could do it. My sense of doing it, preventing it from happening, is to give a course of a antibiotic, either penicillin or azithromycin, for those who are sensitive to penicillin, yearly, once they get into the zone where they would get Alzheimer's disease, and that becomes like a vaccine.
Sure.
So I think of it as a penicillin vaccine, because that kills all spirochetes. They've never been shown to be resistant to it. And you don't develop resistance if you do a short course, which is what I'm thinking of. So I've just outlined that in my recent paper on this issue.
So it's sort of like beating back, what is accumulating over time. And then, the concept that we've discussed, my group was with different scientists, just this idea of screening for these pathogens earlier in life, so
Correct.
that, particularly if we acknowledge that the pathogen can cause CNS diseases. And I think I tend to lean toward using the example of any of the pathogens that can also cause acute CNS presentations, like meningitis or encephalitis. If they can do that, and if there's data demonstrating that a pathogen isn't eradicated with a typical course of antibiotics, which is true of spirochetes, Borrelia burgdorferi can linger even in studies after 9 months of doxycycline. They can grow live spirochetes.
Doxycycline is an issue because the killing dose of doxycycline is twice what the ordinary amount given is. So the prescribed dose of doxycycline is 200 milligrams a day for however many weeks. That is 1/2 of the killing dose, the MIC. So, and the same is true for minocycline. So it's not enough. You have to push it up to 400 milligrams a day. And if anybody's ever tried to take that, your stomach will let you know that it's not fun.
Yeah, it wasn't very well tolerated in that MAID trial, the minocycline for Alzheimer's disease trial that Dr. Rob Howard did in the UK. When they pushed the minocycline to 200 BID, the GI symptoms and sun sensitivity seemed to be prohibit the use of the drug.
Yeah, it's almost impossible to take something that gives a good minimal inhibitory concentration. So the MIC.
You know what, Herb? This is one of the issues with antibiotics is the drugs that we have on the market today. And I've talked about this with my friend who's a chemist a great deal. They are not created to target intracellular pathogens, and they also don't get into the CNS as readily as one would like for the treatment of that type of infection. So it's something that's a really big need, is to have better antimicrobials that have the capability of impacting intracellular pathogens. But really what we have is an arsenal of antibiotics that were created with other germs in mind that happen to have some activity against the things that we're talking about today.
Well, fortunately, penicillin it crosses the blood-brain barrier quickly and easily. And you can get a really good effective concentration of it. And the same goes for azithromycin. And both of them are cidal to the pathogen. So you can cover the terrain with that.
That's good to know. That's very interesting. Well, I very much, appreciate the type of work you're doing, for a variety of reasons. And I'm so glad that we had the chance to have a discussion today, about how, the work that you started with in dermatology, looking at skin conditions sort of led you down a path to start exploring the brain. And, my hope is that more people sort of follow suit and do what you're doing and, leverage their skills in one area to tap into another where there may be a huge need for innovation.
Well, the thing that started me off in the first place was eczema, and it was shown by Dr. Sulzberger, who was the chairman at NYU and an incredible giant in dermatology. Both physically, he was like 6'6", and intellectually, he actually found occluded sweat ducts in the epidermis of patients with eczema, and he thought that was very important. But he didn't have any other probes to study the disease. So I looked at it 60 years later, and those occlusions are made of biofilms made by the ordinary staph, and the staph actually has the gene to make a biofilm, and then the patient has the gene to react and make atopic dermatitis or eczema. So they have filaggrin gene or another that does it. And you put those two together, it's a double hit phenomenon with the genetic and the environmental. And I don't know how much of that is at play with Alzheimer's disease, but some of it has to be, because the gene at the locus AD7 with the early Alzheimer's disease, and then the APOE4 gene with routine Alzheimer's are integral to the story. So
yeah, they sure are. And there's data suggesting that certain pathogens have enhanced entry into cells in people that have 2 copies of APOE4. And I think that's a really important finding that gets not nearly enough attention. But Herb, thank you so much for talking today. I'm so grateful to get a chance to, capture your wisdom on tape, so to speak, to live infinitely on the internet. And, super grateful for the work you're doing. And hopefully what we can do is, as it progresses, get together again and continue our conversation.
Okay, that sounds good.
Thank you so much.
All right.
Bye.